So you use the word marker, so I have to ask this question. So in PACIFIC, we saw some subset analysis with different markers. So when the data first came out in the EGFR positive patients, the data sort of crossed the confidence interval in terms of progression-free survival for the hazard ratio. We don't have the OS data. And then at World Lung, we saw there were maybe differences in benefit based on PD-L1 positive versus PD-L1 less than 1%, to the point where the EU has actually only approved durvalumab following concurrent chemoradiation only in patients who are PD-L1 1% or higher. How do you make these? What do you make of these subset analysis? They are retrospective from large trials, and is that impacting who you're giving durvalumab to right now?
Right. Well, it's sort of interesting because at World Lung, before the data was actually presented, this was the talk over drinks that everyone would have, that in the EU they had restricted based on the 1% cut point for PD-L1, which was particularly unusual because the 1% cut point is not a defined cut point at all in the PACIFIC trial. The PACIFIC trial was designed to look at greater than 25% or less than 25%. The US FDA has been, of course, very reluctant to take sort of an unplanned subset analysis of a trial and do that sort of approach. I do think that, to me, this is a meaningful approach. One of the things that this study, one always has to remember, is this is one of the few times you were able to basically run a PD-1 or PD-L1 inhibitor versus placebo. And that was what this study was. And in this group that had no PD-L1 expression, with all the caveats of unplanned subset analysis, placebo wasn't beaten. And in fact, the survival, at least numerically, looked a little bit better in the placebo group. Would this entirely affect me? Not entirely, but there's certainly, it does give me pause that I already had on patients who I considered not particularly likely to respond to a PD-1 or PD-L1 inhibitor in the first place. Patients with EGFR mutations, patients with who maybe weren't smokers and have low PD-L1 expression. So although there may be some patients who have no expression where I still would treat them, it does make me reluctant among some patients.
Do you get so at our institution, patients with early stage disease, it's kind of like don't ask, don't tell. So we don't know if they're PD-L1 positive. We don't know if they're EGFR ALK positive. Part of the rationale is if they progress to metastatic, we're going to get that information because we're going to rebiopsy and test. Do you have that information available on your patients with early stage disease at your institutions?
We do. We have tried to do that. There are a host of reasons, including a very practical one of not cutting into the slide a whole bunch of times, into the block, excuse me, to make slides a whole bunch of times. So we generally do have that information.
Are you testing everybody?
We reflexively test for PD-L1 regardless of the stage.
Okay.
And so I think all of our patients have that. And part of it's like what Eddie said, efficiency and how to apply that information. I don't really know exactly at this point. So I think Eddie brought up a good point. We've always seen the PD-L1 in the context of other clinical factors, not always, but most of the time.
Yeah, it's hard to know. Every talk that you go to, every meeting ends, we need better biomarkers. PD-L1 was not a great predictor against docetaxel in the second line setting with nivolumab and atezolizumab. So we need the better biomarker to really figure out who that patient is.